Good day and hello. I'm Kyle Clarence. I'm a consultant in cardiovascular medicine at Mayo Clinic in Rochester, Minnesota. And today I'm your host for Interviews with the Experts. Today, our topic is the role of genetics in heart failure clinic. Our guest is Dr. Naveen Pereira, who is no stranger to these interviews with the experts, and he is really renowned in this field. And so I think you'll find that discussion interesting. He's professor of medicine in the Department of Cardiovascular Medicine, associate professor of pharmacology in the Department of Molecular Pharmacology and Experimental Therapeutics. He is chair of our clinical trials operation and director of clinical trials at Mayo Clinic. He's been a longtime NIH-funded researcher, and his research really spans a wide variety of techniques in genetic variants with biomarkers, clinical trials, and recently AI. He's interested in the applicability of genetic variants and how those might be modulated or modulate drug responses based on genetic testing. He has over 150 publications, and although he's received many distinguished awards, I picked out that he has won the AHA's very highly thought of Councils on Genomics and Precision Medicine and Epidemiology Mid-Career Research Award. So with that, I think you can obviously see that he's going to be a great and well-qualified discussant for today's topics on the role of genetics in heart failure. So Naveen, I'll just start with a really basic question. Why should genetic testing be performed in our patients in the heart failure clinic?
So Kyle, thank you very much for the kind introduction. It's really a pleasure being with you here on this virtual platform. In the heart failure clinic, we see a variety of patients. The ischemic heart disease patients are a whole different ballgame in terms of ischemic heart disease patients may have familial hyperlipidemia, and you can do genetic testing for that. And it's important because you can identify family members who may have not developed ischemic heart disease. And we know that those patients have more risk of developing ischemic heart disease and should be treated intensely and early. So we're not going to talk about the ischemic heart disease patients, but in general, I would say genetic testing for non-ischemic heart failure is very, very important. And it's very important, and I look upon it as three major pillars. It's important in providing a molecular diagnosis. It's important in providing prognosis for patients. And now it's important in also helping direct therapy. And we can elaborate on these three pillars as we move forward.
Wow, that's really interesting. And maybe we'll have to have you come back or one of our experts in this field to talk about the ischemic group, because you bring up a really important point. We won't have time to cover that today, but that we can help to predict patients that may have ischemic heart failure down the road before they ever have it. And of course, screening of family members is super important. But what we're going to be talking about today is how molecular genetics can help with confirming the diagnosis, maybe helping patients with prognosis, which of course is very important to most of our patients and their family members, and then maybe modifying the directed therapeutics that those patients could receive. So with all that in the background, then what patients in our heart failure clinic should be front and foremost when we think about genetic testing?
Yeah, that's a very important question. And there are guidelines for this. And in general, I would say all patients with dilated cardiomyopathy, and of course, you have the patients who don't classically fulfill criteria for dilation, but could have non-ischemic, non-dilated, but reduced ejection fraction cardiomyopathy. And I kind of lump all these patients together as dilated cardiomyopathy. It's just easier. And patients with hypertrophic cardiomyopathy, restrictive cardiomyopathy, these are patients who I think should have routine genetic testing. And there's compelling evidence now to do the same.
So, we think about the dilated cardiomyopathy group. Of course, I think about hypertrophy because that's a clinic I spend much of my time in. But the restrictive cardiomyopathies and the non-dilated low ejection fraction cardiomyopathies. So those are two that probably maybe wouldn't have really been front and foremost in my thinking. So that's good.
Yeah, I mean, the primary restrictive cardiomyopathies are rare in general, but there have been genes associated with it. And what's interesting, Kyle, is that the genes responsible for one type of cardiomyopathy may overlap as a causative a gene for another type of cardiomyopathy. So therefore, when we talk about genetic testing, we have a pan cardiomyopathy gene panel, if you may, that covers most of these genes responsible for all three types of cardiomyopathy. Arrhythmogenic cardiomyopathy will fall in the spectrum too.
Is it performed as a simple blood test, or how are we performing it? So basically, you're going to get a panel. You're going to start to think about these things when you're triggered by the non-ischemic dilated, the low ejection fraction, possibly restrictive and arrhythmogenic, and of course hypertrophic cardiomyopathy. You'll get this panel. How do we do the genetic testing? How is it performed?
Right. So in terms of source of specimen, it can be blood. So just a regular blood draw. Patients actually do ask about that because they think it's some elaborate procedure or process. And then they're quite surprised when they say, oh, well, it's just part of a blood draw. And we do have the capacity when we see a new patient, you can actually ask for blood to be stored for molecular genetic studies so that they have one blood draw. They don't have to go back to have another one. So the yield of DNA is probably very high with a blood draw, derived DNA. The other way we can do it, and which is very convenient for the patient, is just a buccal swab. So patients can do that themselves, put the swab in a saliva kit and have it mailed. So there are two sources of DNA, blood and a buccal swab. And then there's the whole spectrum. If someone dies suddenly, if there's an autopsy being done, we have then taken DNA specimens. If there's heart tissue that's being sent, we can also source out DNA from tissue, basically.
And that's actually a really good point. So if you have a relative who dies suddenly, if the family could request at that time that a DNA biopsy, if you will, before the patient is buried or
exactly
cremated and so forth, could be very informative to family members, because it's hard to think about those things when they happen, but it's really important down the road. You'll be asking, I wonder why mom or dad or brother or sister passed away.
It's actually, it has a name. It's called molecular autopsy, and a Mayo pathology and genetics department have really partnered together and provide this service. It's been pretty amazing because when you think of doing genetic testing, also to answer your original question, you really want to do genetic testing on those with the disease. So there's sometimes a lot of confusion. So a patient may come to you and say, my family member had a cardiomyopathy. They don't have it, but they want to understand the risk of cardiomyopathy. And can you do genetic testing? And the answer in general, if their heart's completely normal, you would not do genetic testing in a person who has a family history. You would do it in the relative if the person with the disease, right? That's why this molecular autopsy is important. But the person with the disease should have genetic testing. And if the person with the disease has a gene that's positive, then you will test that gene in the relative. So then you'll be able to identify if that relative is at increased risk of developing cardiomyopathy. So very important concept. Even clinicians get sometimes confused. you really want to test the person with the disease.
Yeah. And I often tell my patients, we'll do the genetic testing on you. It's more important for your family than it is for you because we already know you have the disease.
Exactly.
Yeah.
Exactly.
But there's been slow uptake. I know I've seen it with my patients in genetic testing and for patients with those cardiomyopathies. Why do you think it's been such a slow uptake? And are there any solutions that we as clinicians can help the patients make that decision or work with them to
Yeah,
improve?
no, I completely agree. And people are struggling this in other fields too, like hereditary colorectal cancer. And we certainly have to start paying attention as to how we can improve screening. So just like getting a PSA, a colonoscopy, genetic testing does provide a risk profile, if you may. And if you can pick up patients early and then they undergo surveillance and you pick up disease early, we know, for example, in dilated cardiomyopathy, you can start therapy, even for NYHA class 1 patients. So you can really attenuate disease process. But why is genetic testing not done? And I think we looked at our own heart failure clinic and we published our results. I mean, it was incredible. Just 20% of eligible dilated cardiomyopathy patients were undergoing genetic testing. And what we found was patients didn't want to come back for a genetic counselor visit. And when they came for their clinical visit, there was no genetic counselor visit scheduled at that time because it was uncertain whether they would need genetic testing. And genetic counselors are very busy. There are slots, if you may, appointment slots are highly sought after. So you can't just hold a slot saying this patient may need genetic testing, right? So to incorporate genetic testing in the initial diagnostic evaluation of the patient is key, to do it in a seamless way. So we actually collaborated with the genetic counselors. They were wonderful. They created a video, which is standard for dilated cardiomyopathy. And the heart failure nurses went beyond their comfort zone and went through classes with the genetic counselors and got acquainted with the whole concept of genetic testing and what it means. They were given frequently asked questions, answers, so they could field some of the questions asked by the patients. And they basically undertook the job of ordering the genetic test, which requires a little bit of paperwork. So we had the counseling session recorded. We had the heart failure nurses perform, fill out the paperwork and initiate the actual genetic testing. And then all the patient had to do is go to the lab, or if they didn't want to wait, they could go home. A buccal smear kit could be sent to them, a saliva kit. And by incorporating it with the initial clinical visit, so patients didn't have to come back for a genetic counselor visit, we doubled our genetic testing rate. So from 20% went to 40%, actually.
Wow.
Which is pretty incredible. So what we can do is overcome some of the logistical hurdles with genetic testing, and this is one way to do it.
Have you noticed any financial barriers to patients or even social, barriers in terms of insurance concerns and things like that with your patients?
Right. I mean, certainly those are the other reasons why patients don't undergo genetic testing. There are some commercial genetic testing companies that have become very good, and they've kind of defined the financial obligation for the patient. And so patients know what their financial obligation will be for the genetic testing. And they then work with the insurance companies. And if that financial obligation is exceeded from what the patient thought they were going to pay, then they call the patient and give them an option of running the genetic test. So with that type of arrangement, patients really are well informed and they understand the financial burden, if you may, of doing genetic testing. Most insurance companies, I must say, cover genetic testing now for cardiomyopathy. It's being well recognized because it's important for diagnosis, prognosis, and therapy.
Yeah, and also all the screening that we recommend if they don't get, if they are, just a relative of somebody and they need, screening every so many years, that becomes very expensive for insurance companies as a whole.
That is a very important point, Kyle. I'm glad you brought that up. There was a patient who had hypertrophic cardiomyopathy, was transplanted about 12 years ago, and genetic testing was not that prevalent about more than a decade ago. More genes have been introduced, and her whole family was being screened all the time, whole family. And I saw in the transplant clinic and I said, have you ever had genetic testing recently? And she said, no. We did it. We found the culprit genetic variant for HCM, and it transformed her family screening program. So all the cousins, brothers, sisters, etc., they could now get that specific gene tested, and the ones who did not have the gene variant did not need screening any longer. So it was transformative for that family.
Yeah, exactly. That's why I really try to push for it in patients that I see in the cardiomyopathy clinic. Exactly. I do think it will help with the broader social issue of expensive screening for these groups of patients. So that's great news. And I think it's important to realize how quickly this field is changing.
Right.
Because as you mentioned with that example you gave, how many new genes are coming on, that used to be variants of uncertain clinical significance are all of a sudden either confirmed, yes, this is an important variant, or no, this one we don't have to worry about. I think that's really a piece of information that patients may think, that it's a static thing. Once you're tested, you don't need to be tested again. But I know at least in many of the guidelines are changing to say, go ahead and retest every 5 years or so.
Right. And, as research is being done, the new genes that are being identified. And so, for example, and new conditions that are being recognized, we have, it's rare, but we have identified mucopolysaccharidosis, which is traditionally thought to be a pediatric disease that causes a hypertrophic cardiomyopathy type of phenotype,
Right.
but it's actually mucopolysaccharidosis. But we've identified it in adults. And so we are recommending that the panels add the mucopolysaccharidosis genes too, because they're atypical presentations of these diseases. They're rare, but they're very important to recognize.
How do you think that the genetics provide insight into you kind of already touched on this, but just to really hone in on it, the insights that we get from the genetic testing into the pathophysiology of disease, and maybe specifically those cardiomyopathies? I mean, you just kind of touched on it a second ago, but I wonder.
Yeah, I can just give you a brief example that our research group actually initiated a study where we have patients who are dilated cardiomyopathy, and in our experience, some get better, EF normalizes, and some don't. And the question was simple: is a gene driving this process? And so we did a genome-wide association study called GWAS. We identified 2 genes. We did research on one of them and found that gene actually that was associated with improvement in heart function modulates cardiac fibrosis. So it's a whole different level of thinking as to maybe heart function can be modulated by attenuating fibrosis. So it's novel pathophysiology. It's a gene that no one's heard of. A paper was published in Circulation Research this past 6 months or so. Genetics has really allowed us to get unique insight into disease processes.
Wow, that's really fabulous. There's so many questions that could come out of that observation. I'm sure you're looking into many of them, but not to get too far off track in our discussion here today. Can that kind of information then be used to help develop or target therapeutic interventions for our patients?
Absolutely. And in fact, people talked about it, but right now they're phase 1, phase 2 clinical trials. So the gene therapy clinical trials. Right now, there's a trial on plakophilin 2, which is an important cause of arrhythmogenic cardiomyopathy. And there's a first-in-human phase 1/2 multi-center clinical trial that's assessing the safety and tolerability of gene therapy for plakophilin 2 arrhythmogenic cardiomyopathy. It's an adeno-associated virus-based gene therapy. It's given intravenously. So, and that's also now we have one of the most common causes of hypertrophic cardiomyopathy is myosin binding protein C3, MYBPC3. And there is a gene-based therapy for MYBPC3 hypertrophic cardiomyopathy that's being tested in a clinical trial. So we are a center for Friedreich's ataxia, which is a skeletal muscle, but a lot of disorder, but a lot of these patients have dilated cardiomyopathy and die from it. So attenuating the cardiomyopathic disease process by gene therapy is being looked at in phase 1/2 clinical trial. So it's very exciting. And that's why it goes back to your question, Kyle, that you asked, why should you do genetic testing? If you don't know what was the molecular cause of the cardiomyopathy, you wouldn't be able to then enroll your patients in trials. And soon, once these trials go into phase 3 and they get approved, you wouldn't be able to offer your patients these potentially life-saving gene therapies.
Yeah, that's a very important point. And I wonder how, I'm sure the electronic medical record could play a role. And if you have that gene identified in the electronic medical record, that then your trialists could search for those genes that are positive and then maybe even reach out to patients as opposed to going through the clinicians that may or may not be aware of the trials that are ongoing in the background.
Absolutely correct. Yes. And in fact, the other way around, centers that don't do genetic testing often are unable to enroll patients in trials because they don't know which patient has a genetic mutation because genetic testing wasn't done. So really key, again, to get genetic testing for these cardiomyopathy patients.
Well, super exciting and really fantastic research that many places around the country are doing, but you're certainly spearheading here at in Mayo. And I, as much as I love to leave on that note, I guess there are some uncertainties in our field of research, and maybe we should think about those. And I wonder if you could just point those out to help us to focus on those uncertainties, because I'm certain that as the patients ask questions, that brings up some of the topics that we as clinicians need to be able to answer to their questions. So what uncertainties are there that we need to be aware of?
Yeah, so when you do genetic testing, it's easy when there's a benign result and a likely pathogenic result, right? That's black and white. But there's a gray zone and it's fairly substantial. It's known as variance of uncertain significance. And that kind of hangs on the patient. We eventually, with research and family screening, are able to push those into benign or pathogenic categories. But we still struggle as to how to tease out variants of uncertain significance and define them as benign or pathogenic, likely pathogenic. It's expensive. You could do laboratory-based cell animal studies, but these variants are usually rare, and to engage in a whole research project that may take a while is not done. So there are some groups that do high throughput assays to sort these out. But from a clinical perspective, on a day-to-day treatment perspective, this still hangs over our field. The other thing is, even if someone has been identified with a genetic mutation that causes cardiomyopathy, people are uncertain as to how the gene will express itself and whether that gene will result in disease. So there's some reluctance for people to undergo genetic testing because they don't want this knowledge and the uncertainty of their course. So we really need to do better research to understand the expression of the gene and the disease penetrance of the gene. So those are active areas of research, and I think this will unfold, especially using AI technology. I think we will come up with better answers.
So I think that's something that I've often struggled with in my own practice is those variants of uncertain significance. And one thing we've been doing is bringing those patients back every so often to speak, or at least even virtually to speak with a genetics counselor to see if anything's changed, because sometimes they do move, as
Yes.
you well know. And I also think it's interesting to think about the gene positive, phenotype negative patients. You mentioned penetrance, and earlier in our conversation, you were mentioning the fibrosis gene, which is something that is more of a modulating gene. And I think modulators and penetrance, certainly something that's hard for me to understand as a simple clinician, but I really, I do think that there's just so much information. It's so exciting. It's so fabulous to see how much has changed just in the span of, of our careers, really.
Kyle, I would say that you are not a simple clinician. But,
well, thank you.
But absolutely, I think this field is evolving, and it's important to periodically re-examine the genetic landscape with your patients.
And I think on that note, that's a really important, couldn't have said it better, type of really take-home message that the landscape is changing. Try to talk to your patients about getting genetic testing. There's a lot of importance to now even the patient, which I think that's evolving, but certainly their siblings, their children, even their parents, depending on the age, would be very important to keep this in mind and front and foremost.
Yeah. I mean, the last most heartbreaking thing is your patient's relative died suddenly. I mean, that's happened and it could have been avoided.
Yeah, I have been in those shoes, and
yeah,
so the genetic autopsy.
Yeah.
Or the molecular autopsy.
Yes.
Genetic molecular autopsy.
Yes.
Very important. Okay. Well, Naveen, this has been an amazing career to watch develop over the years. It's been your contributions have been really changing our practice, and it's happening even more rapid as we are standing here today. So I look forward to doing another one of these in the future, and maybe we can convene about the topics, as we brought up a couple of things we didn't have time to talk about today. So I hope you have a great day. And to our listeners, thank you for joining us with Interviews with the Experts. We hope you found this informative, and we'll look forward to the next conversation.
Thanks, Kyle.
Good day.